Doctor, your free phone-in health consultation program. Every Friday from 10 to 11 a.m. brings you health and wellness.
If you're stressed out either at home or at work, or you're having a stressful relationship between either your girlfriend, your fiancé, or your wife, you can have erectile dysfunction.
Call in to get free consultation on health and wellness on 07000 917 917 and 090-256-25455. You can send in questions, cases, and related contributions on social media, Facebook, Twitter, and Instagram at WFM917. Text and WhatsApp on 070-317-56537. You can listen live online at www.wfm917.com. Radio Doctor, Nigeria's first free consultation radio health program on WFM91.7, the voice of women.
Okay, time checking is 6 minutes after 10 this morning. First of all, thank God it's Friday. Thank God it's Friday from the craziness and the sadness and the turmoil of this week, because this week as a country, as individuals, it was such a dark week for every single one of us. And we're hoping that we don't experience this anymore. But hopefully this weekend is better. We get a bit of respite from the craziness of this week, and we see action from the government. Hopefully, my fingers are crossed. I'm hoping, but I don't want to say the other parts because Nigeria we day. Anyway, this is Women Radio 91.7 FM, the voice of women, Nigeria's first and only radio station for women and their families. You are listening to Fumi Bangwala on Radio Doctor this morning, your free health consultation program where real doctors advise real people. Radio Doctor is Nigeria's first specialized radio health program where medical doctors consult for free and advise on your women radio. Radio Doctor is broadcast Mondays through Fridays, 10 a.m. to 11 a.m. And our radio doctor for this morning is Dr. Abiola Ajayi, the MD CEO of ROA Specialist Hospital. Good morning, Dr. Abiola. How are you doing?
Good morning. I'm on video this time.
You are. I wasn't going to say it. You are. First of all,
you guys don't. You don't know I had an accident and I broke my arm, so I had a cast for the last 2 months. That's why I didn't want to be on.
Oh, I'm so sorry.
So the cast came off a few days ago, so I'm back.
So sorry. How's your arm now?
Painful.
Oh, sorry.
But I still got a smile, no problem.
That's good. Thank you for your PA had reached out to me. I don't know if she told you what I said. I was like, what were you expecting me to eat when you removed everything from it? So I'm giving you.
Oh, you got the guy. You got the guy.
Yes, I did. And I asked. I think I was speaking to her for maybe 3 days. I said, "Please, what is Dr. Abiola expecting me to eat?"
I just ate something great, and it fits in the menu. The next thing I'm going to do is do recipes, and I'll have links for the recipes. Try them, and before you say that.
Okay, because you remember everything.
I've cooked every day for the last 2 weeks, and the food has been fantastic. Okay. High protein, low carb, very tasty.
I'll wait for your recipe and see. But I gave that guy the side eye. I was like, huh? What's going on here? And I told her, I was like,
Okay. Now that I know that you said something, I'll step it up on the recipes. I've put a few together. I'll start posting them. Try one or two, and then you'll sing a different tune. Elizabeth is starting it next week. She's starting my diet. So I said I will cook one meal a day for her so she can try it and learn it and see.
Okay. Anyway, today we are going to be talking about superbugs and self-medication. How yes, what that word is, resistant.
Antimicrobial resistance.
Thank you. What Dr. Abiola said. It's fueling outbreaks in Nigeria. You can listen to us live, www.wfm917.com, or you can watch us live on YouTube at WFM917 to join in on the conversation. The phone lines will be open shortly, 07000 917 917, 09155 917 917, or you could text and WhatsApp us on 08155 917 917 or 0703 1756 537. Okay, now that is out of the way. Dr. Abiola, what exactly are superbugs and how do they develop antimicrobial resistance?
So when you hear superbugs, you think about Superman. So a bug with a cape, right? No, okay. I'm joking. Superbugs, they're not bugs with capes. They're special species of germs that have become so resistant to the medicines that our usual drugs do no longer work well.
Okay.
That's it. So it's the same bacteria, or the same, using the word bugs to include all different organisms, but it's the same ones. They just become resistant to the medicines we use to fight them. And normally when you take an antibiotic, it kills most of the bacteria causing the disease, but a few naturally tougher bacteria may survive. In school, we learned about something called natural selection, or survival of the fittest, right? And, there were many different species of humans, and we're the humans that decided to, or that were stronger and smarter and lasted. Same thing goes for bacteria. So when you have some that are naturally resistant or a little bit more resistant to the medicines, and those tougher bacteria may survive, especially if antibiotics are misused. And I think we'll talk more about that later. But over time, you now develop these superbugs that can resist even all or almost all available antibiotics.
Can you give examples of what the superbugs are? Because when I think about bugs, the only thing I think about are bed bugs and beetles.
Yeah. So let's say bacteria for now, right? Okay. And the majority of what we're talking about is bacteria. So over 1.3 million deaths were attributed to drug-resistant bacteria globally just last year. And it's, I'll give one example. A bacteria called MRSA, MRSA, methicillin-resistant Staph aureus. So Staphylococcus aureus is a bacteria. I teach microbiology sometimes. So it's a gram-positive bacteria. It lives in our skin. So it lives all over us. We naturally have, if you touch your nose, there's staph on your nose, there's staph everywhere. But this particular staph is resistant to most of the antibiotics that are supposed to kill it. And it can now cause flesh-eating disease, where your flesh literally gets eaten from the inside out and no cure. You see it sometimes in hospitals that have a lot of resistance. So any bacteria can become a superbug, so to speak.
Right. Okay. So what is the situation in Nigeria or globally? Like, where does Nigeria stand in this crisis? Because you mentioned 1.3 million. Is it million or billion? You said
1.3 million worldwide.
Worldwide. So where does Nigeria
from just from resistant bacteria? But a lot more people get sick. And like I said, it's not completely resistant. You have some that are completely resistant. You have some that are partially, and some that you require such strong antibiotics that you can actually damage. I have a close family member that had a very strong infection. The type of antibiotics they had to use were so strong it damaged the person's kidneys. Ooh. And now the person needs a kidney transplant. So you had to decide whether die from the infection or eventually end up needing a kidney transplant. It's that serious. So, in the States, there's 3 million of these infections a year, and 50,000 people die. These are, rough estimates, but there was a study done by the World Health Organization. About 40% of samples that were sent in had some degree of resistance. So this is something. And we don't have a lot of, I think I haven't brought a lot of myths in so that we can work some of those in. And one of the myths is that, if the antibiotic my doctor prescribes doesn't work, he'll just prescribe a stronger one. We do not have an endless ladder of strong bacteria. It's not endless. At some point we get to the last bus stop. And when you're there and the bacteria is resistant, then we're in trouble.
Now, in a country that depends heavily on antibiotics. How does this bode well for us?
For Nigeria, we have lots of infections like everywhere in the world, but some of our processes are different. For example, in Nigerian hospitals, they show that, remember I talked about that MRSA, methicillin-resistant Staph aureus. They saw about 70% of them resistant to the strongest medication in some of these government hospitals. And meaning about 50% of people in some communities. One of our issues, and I think we'll talk about this more, is that we have unlimited availability or limited access to antibiotics, right? So there's some areas that 70% of pharmacies now give antibiotics without a prescription. And about 30, anywhere from 50 to 70% of people will go and seek out an antibiotic without doctor's advice or without a prescription. When I first started with WFM, I didn't have many patients, so I would go and visit pharmacies and tell them about myself. And so I would stand there. The first day I stood there just waiting for the owner to come out, I saw a customer come in and he said, let me have some this headache medication. And then he said, I just want to flush my system. Let me have named a particularly strong antibiotic.
Yeah.
And the sales girl asked, how many do you want? I said, no, just one so I can just flush. One tablet. I just want to flush my system. I looked at it. I said, sir, are you feeling ill at all? No, I'm fine. I'm strong. I don't want to. I said, geez, I almost fainted. I said, this is the problem. And the salesperson did not stop him. The owner did not stop him. They happily sold him that one tablet of antibiotic for no reason. So
when did antibiotics become a flush? That's what?
I have no clue. I'm not trying to be tribalistic, but a lot of this ideas are more from our people in the north. They believe in that flushing of the system with antibiotics. Some of us down south do too, but a lot of us down south will go to the herbal concoctions and things like that before now going to the chemist. I kind of seen that through the different people, but it's all wrong at the end of the day. And I see people that use herbal concoctions burn up the liver, burn up their kidneys. Those things are not safe either. So I just watch and wonder, as some things can do.
Okay, so how does antimicrobial resistance, how does it affect everyday life? Because obviously, because it's something that's within the system, it's not something that you can see. But how does it affect, everyday life for the person who has it?
Yeah, so, it can all start with a simple infection. So a simple, average woman will get a UTI at some point in her life. It's just part of being a woman. It's nothing that they're particularly doing. So that's UTI, urinary tract infection. And typically, if you come into a hospital setting, they'll take a sample of your urine and they'll test it. They'll first try to grow what bacteria is inside, and then I'll test it against some common antibiotics. And they would now recommend the one that works the best to the doctor. So if the doctor provides this drug, you take it once a day for a week to clear it, a lot of people will stop using the antibiotic as soon as they feel better. So, and usually that's way before, guilty. And usually that's way before the bacteria have been killed. So you don't feel better when all the bacteria are gone. You feel better when the bacterial load goes down.
Right.
You think about it, the weaker bacteria die first. The stronger ones die later. So you now stop the antibiotic and you've just left the strong ones behind. Ooh. So either you get reinfected and now you try and go back and use that same antibiotic. It doesn't work because the ones that are left behind already know how to be resistant to it. Right. Or your immune system will go around and eat up a lot of them and kind of keep them in check. You may not get sick then, but you may get sick later. And you can pass it to someone else, and their immune system may not be like yours. And this is how one person's mistake becomes a mistake for everyone. That bacteria with UTIs and other types of infections, some of them are sexually transmitted. Some of them can be transmitted by sharing certain living spaces. And so you can now infect other people with these superbugs, and they may not respond the same way that you responded. So it's simple. Same thing with a cough. Same thing with skin infection. Any infection you don't treat properly or you misuse your antibiotic has a chance to develop into this.
What makes us as a people just rely more on self-medication? I mean, citing the example that you gave, he came to... I don't even know how to ask this question because I know that I am guilty of the same thing. So I'm trying to not cast myself too much. But what makes us so self-reliant on, over-the-counter drugs when we go to the pharmacy to get it, and then the pharmacist, like the example you said it again, did not ask any question, what's wrong with you? Is it cultural factors? Is it socioeconomic factors? What makes us do that? Even for people who have HMOs, they'll still rather go to the pharmacy and treat themselves than go to the HMO, which is sort of free because you're paying for it in some way. So it's like you're paying twice for something you could have gotten for once. Yeah,
70% of Nigerians do not have an HMO. So only 30% of them have HMO. So 70% of Nigerians are paying out of pocket. Another 70% of them are using antibiotics without prescriptions, just going to the chemist. Another 70% of chemists and pharmacists will give you drugs, antibiotics without a prescription. So these are some of the things that are perpetuating this issue. Even some hospitals and clinics, I teach this stuff all the time to my doctors and my staff, but I see it from other hospitals all the time. Inappropriate dosing of antibiotics. It happens in hospitals and clinics as well, because a lot of us don't continue to read. What was correct 10 years ago is not what's correct in medicine now. It's called the practice of medicine, meaning you continuously practicing, trying to get perfection. You can never be stagnant in medicine. You need to read. I read a medical topic almost every day of my life to keep up. But a lot of people, once they hang their certificate, that's the end of reading, and it can cause issues. Another one is that we sometimes don't want to run tests. You just come in and say, "Doc, I know," or go to the chemist, "I know what I have. Give me something for malaria," or "Give me something."
But I know what I have, though.
I know what I have. So we're not running any tests. And something that we don't think about, I actually went to Osun State and visited one of the largest poultry farms in Nigeria. They supply probably half the chicken in southern Nigeria. And the use of antibiotics in agriculture and poultry is huge. 80% of poultry farms in Nigeria are using antibiotics routinely. And these antibiotics get into the meat. They get into our body, they run off and get into the water, get into our drinking water. It can drive not only antimicrobial resistance in humans, but also in animals through the environment. So that's something that we don't think about. And the final one I'll throw in there is weak or counterfeit drugs. In the terms of antibiotics, I'd rather have an antibiotic that was just chalk than an antibiotic that said 500 milligrams and it was really only 200 milligrams. Because the underdosing of antibiotics can also lead to. So if I took the one that was chalk, I wouldn't get better. I'd probably go to a different place or buy from a different person. I would know because I'm still sick. But if I'm taking the low dose one, I could just be setting myself up for resistance. Both are wrong. Both are illegal, but we have poor enforcement here. In the States, the Food and Drug Administration samples drugs at random constantly. Okay. And if you don't have at least, I think it's 80% of the active ingredient in the tablet, your drug is banned. And they'll take stuff off the shelves, not just the stuff the company sends in. They'll go into a CVS and grab stuff off the shelves and go and test those. We really need to step up in enforcement.
Okay. So, you sort of touched on antibiotic resistance, and it's safe to say that the cause of antimicrobial resistance is overusage or underusage of antibiotics, right?
Yeah, so 5 engines drive it. 5 things: self-medication, poor prescriptions, weak labs, farm misuse, and fake drugs. Those are the 5.
Right. Okay. So for people who do not understand what you mean by, resistance, can you blow it out for people because you had given the example of when you take the drugs and you use it, it's the weaker bacteria.
So we all have immune systems. Okay. We all run into bacteria. Like I said, we have bacteria that live on our body. So staph living on our body, on our skin is fine because our skin is our number one immune system. It protects us from pathogens or things that can infect us entering our bloodstream. But if you take that same staph and inject it into your bloodstream, it can cause all kinds of infections. Go to the lung and cause pneumonia. So you have an immune system that's constantly searching for foreign bodies, foreign bacteria, viruses, and eating them up or killing them in some way. If your immune system, think about your immune system like an army. So if I have 100 soldiers, then I know that if I have 50 enemies, my 100 soldiers should be able to kill them.
Okay.
But if I have, they should be able to take them one by one. I still should have 50 soldiers left. If one takes out one, I still have 50 left. But if I have 100 soldiers and I have 1,000 enemies, then I'm going to need help.
Reinforcements.
Right? Mm-hmm. So the reinforcements, like better guns for the soldiers, would be antibiotics against those bacteria. Mm-hmm. But not every soldier is the same, right? Some of those soldiers have been in training for 20 years, and some of them just joined the army, right? So the ones that just joined, they'll be dead first. That's just what happens.
Okay.
Right? They won't know how to duck and move and bob and weave, so they'll be dead first. The hardened soldiers will stay around, and they will start to learn the tactics of your army. That, you guys come from the right, and you shoot like this, so we are going to flank you and come from behind. This is what the bacteria do. The bacteria learn how to defeat the antibiotics, and they teach each other. There's something called a plasmid, and they will send a signal to their neighbor and say, hey, I know how to defeat this bacteria or this antibiotic. Here, take the signal. And they'll send plasmids to each other, so they develop their own army of resistant bacteria. So you're trying to use the same bullets, same antibiotic, doesn't work.
Right.
That's the main way to describe resistance. I think that's the easy way.
Oh yeah, that was pretty. Yes, even for me, I'm understanding it. And then you had said that, so because there is drug abuse, let's call it what it is, or antibiotic abuse. For instance, the moment where I don't finish my drugs because I feel like I'm feeling better, when I fall sick again, I infect somebody else who most likely has also abused the antibiotic, and then I spread it to that person whose immune system is obviously weak, then spread it to somebody else, and then that's how it continues.
That's one of the main ways. Another main way is for people like you that don't finish their antibiotics.
I don't use my example again.
And their friend says, I have a cough. You're like, I didn't finish my cough medicine here.
Oh, I don't do that. No, I don't do that. I know that when you do.
Okay. But if that happens, remember I said it may take 7 doses of an antibiotic, but, somebody, not you, somebody stopped using it after 3 doses. So you have 4 doses left. You share 4 doses with your friend. That 4 doses is not enough to kill, so they're not going to have the same problem. Whether they got the infection from you or not, it's underdosing is also part of the problem with resistance.
Wow, it's a vicious cycle. Is that why even common infections are becoming harder to treat? So, for instance, if you go to the hospital and say you have malaria, they give you the normal prescription. It's like, the person still has malaria. They have to give you what we would typically say, they want to give you a stronger one that will work faster. Is that what's causing it?
Yeah, so when we're talking about antimicrobials, we're typically talking about bacteria. So malaria is a plasmodium. It's a different class of infectious agent, but it does have resistance. They do have resistance. So
Okay.
the anti-malarials we used 20 years ago, like chloroquine and quinine and stuff, those don't work as well. And when I have a serious malarial infection to treat, I always use two agents to combat
Okay.
resistance. So if I do use CQ, I have to combine it with something else. The average, what I used to use maybe 5 years ago, but now not so much. The average over-the-counter antimalarial that we all take always has two drugs in it: artemether and lumefantrine. And artemether is supposed to go through and kill the malaria, and lumefantrine goes into the liver and the organs and pushes out, because malaria goes to hide. Once it sees antimalarial in your body, it will go and hide in your organs. And so you have two agents, and most of those, what they call ACTs, take them over the counter, two agents to try and reduce resistance and eliminate all of the infectious agents.
Okay, so how does, if we're talking about treatment, how does this antimicrobial resistance, how does it affect treatment outcomes for the people that are more, less immune? How do I explain this? Like children, vulnerable people, yes, children, pregnant women, older adults. How does it affect their treatment outcomes?
Affects everybody. When we're talking about resistant strains, they spread faster because a resistant infection takes longer to clear, so the person remains infectious. Remember that if you have a cough and you're coughing, you can infect other people until you've killed enough of that bacteria. So a resistant infection takes longer to clear if it does clear, but the person can now infect others for longer. So that increases what we call community transmission of the bacteria. Then it also increases treatment failures. So a patient may take, I may treat a UTI for a week, give drugs for a week, and at the end, the patient may still not be better, or the bacteria may not be cleared because the bacteria was resistant. So what should have been a 3 to 5 day illness now becomes a 2-week illness, and you just have longer time to spread infection to others. And one of the scarier one is something called nosocomial or hospital outbreaks. So, most of the people that come to a hospital are sick, and most of them will have bacterial infections. And so anybody coming in with a resistant bacteria can now spread that to other people in the hospital, not just the workers, but other patients. And that's where you get things like the MRSA I talked about. There's a strain of E. coli, which is found in your digestive tract, that's also resistant. And when we say resistant, we were talking about resistant to some of the strongest antibiotics that we know for those. So there's some hospitals in Nigeria that have 70% MRSA, which is that methicillin-resistant Staph aureus that can eat your flesh. We, in ROA, at least once a quarter, we will swab door handles, operating tables, desks, chairs, and just grow whatever grows there, and make sure that we're keeping up not only with our sterile practices, but we don't have any strange bacteria growing. We even do the same with our water, our borehole water. At least once a quarter, we test. And if anything is found, that section, we've not found anything in 10 years, but the protocol is, because I may not see about cleaning, so we will sterilize the day before surgery, we'll sterilize, minutes before the surgery, we'll sterilize after the surgery, sterilize the place every day. And it's been working. So, but 60 to 70% of some hospitals have some of these bacteria, these resistant bacteria in there. So, we have to really be careful.
You people don't used to talk to each other, Abby, because I'm thinking, like, what do you mean some hospitals have 50 to 60% of this?
Yeah, so just like I said, I'll swab, I'll swab my door handle because I'm paranoid. I'll swab the bathroom doors. I swab the consultation couches where the medical officers stay and the operating rooms, and we swab them separately and grow separately. We want to see what bacteria. You're always going to have some bacteria. That's not uncommon, but what bacteria are growing? Are these resistant bacteria? And the type matters. If I find Staphylococcus on the door handle, nothing you can do about that besides wipe it down with an alcohol swab. The next time somebody touches it with their hand, staph will staph will show back up again. That's fine. But if I see something called Proteus mirabilis, I'm going to be frightened. If I see E. coli, I know that somebody's not been washing their hands. E. coli can cause big outbreaks, so the types, and then we'll still test it against antibiotics to see, are any of these resistant? All the ones that we found in the last 10 years, they're not resistant bacteria. Like five, 6 different common drugs would have worked against them. Yeah. And I don't find the ones.
What is the medical association or what the medical board? I don't know what pharmaceutical boards. What are they doing to reduce this? How are they regulating the contribution of the antimicrobial resistance in the country? Because I would like to think that they should be on top of their game when it comes to things like that. Are there routine checks that they do in hospitals? I know that we're in Nigeria, but this is the medical sector we're talking about.
Yeah, eventually we're going to have to stop saying that. Eventually we're going to have to stop saying we're in Nigeria. We have to step our game up. Before COVID, I was part of a group called SOAR, S-O-A-R. It was some structural organization against resistance or something. So we had meetings. We would talk about antimicrobial resistance. We'd talk about regions of the country. It was like a medical conference for hospital directors and doctors. And I thought it was so interesting. I absolutely loved it. But I've not heard about anything like that. If somebody listening has heard about it, please send it in. But it died after COVID, and I don't think we've really stepped it up. So it's almost like every institution is on their own, and it's up to their own policies. A lot of stuff falls through the cracks. Not everybody. I'm not saying I'm the best, but I know how much energy I put into it. And I'm very sure not everybody is doing like what we're doing here.
So basically, there's nothing that's been done from the Nigerian Medical Association, from the NARD, from the pharmaceutical boards. That's what you're saying. Okay,
you will never hear me speak against any organization. Because I'm going to say everybody's doing their best. Everybody's doing their best. I can only control myself and what I'm doing, and I can help. If anybody needs my help, I will help. That's all I can say. That's all I know. Really, I don't know what other people are doing. Don't let me lie.
Okay, what about counterfeit drugs? Because obviously, I'm thinking that the reason why there's a spread of this antimicrobial resistance is also due to counterfeit drugs. So, for instance, I was in my daughter's old school. The head of school had some brain thing that she had to go to America to treat. Comes back to Nigeria and she had some drugs she had to take. And in one of the times I was in her class, she showed me some drugs that she was taking that were expensive to buy, but they were fake. Oh, she continued to take them. She was like
because you spent money on it.
Yeah. And I think there's also the issue of, I don't even know which one is original and which one is fake. How did she find out that it was fake? The doctor told her. So, unfortunately, you can't drag your doctor to the pharmacy, especially if the hospital that you're going to does not stock it or they're out of stock. So what are the steps to, how can I even know that the drug I'm buying is fake? Because obviously if I use the drug now and it's not working, then it means that I'll have to go and buy another one because that one did not work, which means that the one that was fake has done damage to my system already. Yeah.
The best thing you can hope when taking a fake drug is that it has nothing in it. Because there's some things that can be in it, some agents they cut it with, and that can actually do serious harm. And I always tell my patients this. I said the most expensive drugs are the ones they're going to fake, because that's where the money is, right? Mm-hmm. So if I have a box of this antihypertensive that I know sells for 10,000 naira for a month's supply, and I have a box of headache medication that sells for 500 naira for a month's supply, which one am I going to put my energy into faking? The more expensive one, right? So there are markets where you can buy drugs in Lagos. There are open markets. I've been there a few times. I've seen directors and wives of other hospitals in that area. The time I went, because I was told the way I was getting my drugs was too expensive and was not how we do things in Nigeria. So somebody, a nurse, well-known nurse, took me, said, this is how you buy drugs in Nigeria. Took me down to this Isa Leko.
No way.
Brent, you know I speak Yoruba now.
We have a call. Hello, good morning.
Okay, go ahead.
Hello, good morning, Women Radio. Hello, good morning, Women Radio. If you can hear us, we cannot hear you. Maybe do well to call us back. 07000 917 917 is the number to call. 09155 is also the number to call. Okay, please go ahead, Dr. Abiola.
Yeah, so in some of these markets, it's hard to regulate. I went, it's just crazy. So people everywhere.
Were they selling original drugs there?
What's that?
Were they selling original drugs?
Some places, and some places were not. And those places are right next to each other. You know, recently the area was shut down by the Minister of Health. And he started raiding. You know, that just happened a couple of months ago. He started raiding. I don't want to talk political business. So something happened. Yeah, go ahead.
Hello, good morning.
Hello.
Hello, good morning, Women Radio. It might be your network. Try calling us back again. Please go ahead, Dr. Abiola.
Yeah, so, you know, something happened and you went and started raiding and you find a lot of these drugs, no NAFDAC number, no, you know, and most of those are fake or, and we say fake, sometimes they fake them here in Nigeria. Sometimes they're fake from China. There was a time early in my Nigerian career, I went to India to visit some of the drug making factories, and I got a contract for a couple of drugs that I use and they're like, oh, you're from Nigeria. How much drug do you want us to put in? I said, all of it. I didn't fly all the way here.
Hold on a minute. When you say how much drug, not in the package, but in the making of it.
So in a 500 milligram tablet, they asked me how much would I like to put in each tablet. Would I like? They didn't even say how less. Do you want 100 milligram or 200 milligram? Nigeria. I said no. I want the 500 milligram. I want everything. They said, oh, okay. It'll cost. I said, yeah, it's going to cost more because it's more of the drug. This one is cheaper. I don't want the cheaper one. I want the full one. I made that clear, and I left with the contract for them to send me the drugs. But they will easily send you a 500 milligram tablet with 50 milligrams of drug or 100 milligrams of drug. They'll make it how you want it. China will do the same. So the way I get my drugs for this hospital, most people think our drugs are expensive. And yeah, I'm sure they are more expensive, but the trouble I go through to get them is for a reason. I can trust everything that I have on my shelf, because when I get a new drug, if I turn my camera, you see there's a stack of drugs. There's a stack of drugs on my shelf. Mm-hmm. I test every new medication. Whether I test it on myself if I have an ailment, or I'll test it on a patient that I trust, and I'll track it. So I'll call them, see how you've been, did you have any side effects? And once I have a good track record, I'll now take it and put it on the shelf. You know, I do that for every single new drug. Not one new drug goes on the shelf before running through my office. It's a pain, it's difficult, but I feel compelled to do it, especially now.
Wow. So in essence, there's no straight cut way for Nigerians to identify genuine, antibiotics versus the one down.
Unless you have a drug testing kit, it's based on trust. So, now I get direct from the manufacturer. I have contracts with the factory, so they'll ship directly to me for a price. Or I have reps that go to the company and get, sometimes some of these are French companies, some are Indian companies, some, are around the world. the U.S., most of their drugs come from India and China. It's not like America makes a ton of drugs. About 80% of them come from out of the country. But everybody knows you can't send fake drugs to the States. They'll ban you, tariff you. No, they won't take it because they're going to test those drugs when they come in. Nobody in the States is asking for fake drugs because they just can't get away with it. I'm talking about nobody that's a commercial seller. There's still black market everywhere, but here a lot of people are requesting for it. We request fake everything, fake electronics, fake drugs, and what they do, if I'm going to go buy a container, I'm going to buy 3 containers of drugs. I'll buy 1 container of the original. Then I buy 2 containers of the fake. I'll now sell the first half of that container of the original. I will sell. That's what will drive the market response. Oh yeah, this drug works. Then I now start mixing in the fake. This is what others told me to do, and I said no.
Oh, we have a call. Sorry to interrupt. Hello, good morning. Okay, the network, I think it's the same person trying to call because he keeps trying to call and it keeps going off. Wow. I'm feeling so shook right now because it's drug.
I'm not fabricating. I'm not exaggerating. This happens every day.
So we're moving on vibes and inshallah. That's good. It's good that we protected all of us. Anyway, so what can individuals or communities or government institutions, how can they start, just to get back to the conversation, what can they start doing? What are the things they need to put in place to prevent antimicrobial resistance from spiraling out of control?
I mean, I would never tell government what to do, but coming from a place, I have to say that I don't want any trouble. Coming from the U.S., the fact that you cannot get drugs without a prescription makes a big difference.
Yeah.
Right. So even antibiotics, you need a prescription to get antibiotics. For pain medication, for all the kind of medication, you need a prescription. So and truth be told, some of our larger pharmacies are more commercial pharmacies are requiring. I've gone, maybe I'm in Lagos, I'm not close to Aripo, and I need some medication. I've gone into pharmacies, not dressed like this, dressed regularly, and they demanded a prescription, and I was impressed.
Okay.
I said, really? And a couple of times I'll say, oh, I'm a doctor. Sir, I still need a prescription. I'm like, let me go to the car. I have a prescription pad in the car. I'm coming. So, I mean, I love it. Some of them are doing, but it's about only 30% are demanding prescriptions. About 3/4 of them are still doing it. So I think that over time that will improve. And if government stands behind those practices, I think that will make things easier. And then we need to start having more discussions, with the hospital, private and public hospital discussion on, hey, what can we all do to reduce antimicrobial resistance? Because we have to work together. If private is by itself and public is by itself, those people, the community still cross. So we're still causing problems for ourselves. So conferences, and I don't like to talk about more regulation because I come from a place that's overregulated. So, but more education would really help.
All right. Thank you so much, Dr. Abiola. Today was an eye-opening session for me because you
didn't think it'd be so interesting talking about bugs, right?
Yeah, that's what I thought. I was like, oh, yes. And I didn't even check or to Google it. I just thought, bugs. No, I will talk about this one. Wow. Okay. An eye-opening session for me. So call me very, very educated. Thank you so much. Dr. Abiola is the MD CEO of ROA Specialist Hospital. Fun fact, I thought your hospital was on the island. I only found out on Wednesday. On Wednesday. So we had. Yeah.
We're neighbors.
Yeah. I don't know how it didn't click because I pass the hospital every time I'm at the office, but it never just clicked that was the same hospital. So somebody had to come to the. We had a global World Toilet Day on Wednesday, and the executive secretary of the Youth Empowerment Foundation had come and was asking about Radio Doctor and what we do, and said, "Oh, so Dr. Abiola?" I'm like, I'm not sure we're talking about the same person. She said, she keeps going, oh, ROA. I'm like, no, the one that I know is on the island.
I'm going to open a branch there.
Okay.
Hopefully within the next year.
Okay.
But this will always be the main. This will always be the main branch.
Very well. It was quite interesting. So I didn't even know. But so yeah, Dr. Because I think the last time you said some people came for the free what's that thing for the cancer thing for men. I was like, people really left this place to go all the way to the island. Wow, it did not click.
But I have a lot of patients that come from the island.
Oh.
I have a patient call me yesterday coming from Asaba. I have a patient today coming from Abuja.
Wow.
I have patients from Owerri and Nugu, all over the
well,
country.
like they say, when you're good, you're good. When you're bad,
Hey.
you're bad. Look at that. All right, you can reach Dr. Abiola www.theroahospital.com or by calling him on 0913-579-5108. And then you can call the hotline, the number for appointments and directions, 080-888-626-35. Also again, 080-888-626-35. And you can reach out to Dr. Abiola on any of the social media pages, ROA Specialist Hospital. Thank you so much, Dr. Abiola, for coming on the show today.
My pleasure. Have a good weekend.
You too. Enjoy the rest of your weekend and your day. All right. Many thanks to you, our listener, for calling in, for the person who was trying to call in, and for listening. Radio Doctor is on Women Radio, and it's Nigeria's first specialized radio health program, broadcast Mondays through Fridays, 10 a.m. to 11 a.m. Join us on Monday for another episode of Radio Doctor. Many thanks to my producer.